Hello everyone, welcome to my YouTube channel Logicmedico. Today's interesting topic is oculomotornerve and why it is called so. So before going to the topic, if you're new to my channel, I request you to subscribe to my channel and press the bell button for the latest notification. It will be there in this corner, lower right corner. So here in this patient, you can observe this eye is in neutral in position, whereas this eye is slightly diverged outwards. So why it is diverged outward? Because that lateral rectus muscle and the nerve supplying that abducent nerve is intact, whereas oculomotor nerve is paralyzed. That is, the third cranial nerve is paralyzed. So when the medial rectus is paralyzed, the unopposed action of the other muscle, the lateral rectus muscle, which is supplied by abducent nerve, will pull that eye towards outward direction. That is called as divergent squint or the lateral squint. So details of this you will understand if you concentrate and listen to the third cranial nerve in detail. So the objectives for today's presentation is to describe the nuclear origin, functional components, intracranial course of the third cranial nerve and list out the branches of this third cranial nerve. Initially, I will tell you about something about extraocular muscles. The extraocular muscles are four recti, recta means straight muscles, and two oblique, which are oblique to the eyeball, okay, and one of the muscle which is applying the upper eyelid and it's elevating the upper eyelid actually. So palpebral means upper eyelid, it elevates the upper eyelid. Levator palpebrae superioris. Superioris means upper, palpebral means eyelid, levator means it will elevate. So third, fourth and sixth cranial nerves, they supply the extraocular muscle. Third is oculomotor, fourth is trochlear, sixth is abducent nerve. You can see the other videos of mine on trochlear and abducent nerve. The description link is there, and even you can just put this nerve's name and put logicmedico, you will get it in YouTube. Okay. Extraocular muscles, the four recti muscles, the superior recti, it will elevate the eyeball, the inferior recti depress the eyeball, medial recti adduct the eyeball, lateral recti abduct the eyeball, two oblique, the superior oblique will pull the eyeball downwards, forwards and medially in an attempt to see the tip of the nose, that is called intorsion. The inferior oblique pulls the eyeball backwards and upwards so that you can see to one of the corner of your room, okay, that is extorsion. So those are the action. Levator palpebrae superioris will elevate the eyelid so that you can open your palpebral fissure or the eyelid fissure and your eye can see the light entering into your cornea. It will elevate the eyelid. After a certain time it will get fatigued or tired, okay, so you will blink. So why you will blink? Because of the fatigueness of that muscle, levator palpebrae superioris. All these extraocular muscles, whatever I described until now, are supplied by oculomotor nerve except two muscles. We'll see that. You can keep this as your password for your mobile. If you forget, you can see this video one more time and you can note down these things. Okay, SO4 LR6. If you try that for one day at least, then you will remember this throughout your life. Okay, so all the extraocular muscles are supplied by oculomotor nerve except SO4 LR6. So what is the full form of this? We'll see. SO means superior oblique, 4 means fourth cranial nerve, which is called as trochlear nerve. That is called so because that nerve will pass through, will supply a muscle superior oblique, which will pass through a pulley called trochlea. Then another muscle, it's LR means lateral rectus. That muscle will have action pulling the eyeball towards one side. So that is away from the midline, which is called abduction. Therefore the nerve is called abducent nerve. The sixth cranial nerve is therefore called abducent nerve. So all the other extraocular muscles are supplied by oculomotor nerve except these two muscles, superior oblique SO4, fourth cranial nerve, which is trochlear nerve, LR6, lateral rectus, sixth cranial nerve, which is abducent nerve. So kindly remember this statement. It will definitely fetch you more than enough marks and more than enough clinical points for diagnosis. So here is the various movements possible. Kindly look at the prime movements only. It's a neutral position, okay, neutral position where the eyes are looking straight forward. Here this action is called elevation. It's brought about by superior rectus. This action looking down at your feet is Inferior rectus will bring about this. This action is called depression. Okay, this looking at sideways, this one. Here there is abduction of the right eye. Here there is abduction of the left eye when you look at the left side. This one seeing towards the midline, towards your nose. This is adduction. This is adduction of the left eye for the patient. This is adduction of the right eye. When one eye moves abduction, the other eye will be adducted. That is called conjugate eye movement. That is moving parallel to one another, so that we should not get any diplopia. So therefore, you may get confused with abduction, adduction. Just look at this one eye. Movement away from midline is called abduction. It's brought about by lateral rectus. Movement towards the midline in this eye, you can see there is an adduction. Okay, this is extorsions. And if you try to see the tip of your nose, this is definitely intorsion. This one. You're trying to see the tip of your nose with one eye. This is intorsion of this right eye. This right eye only, see. This is seeing upwards and outwards into this corner. This is extorsion brought about by inferior oblique. Intorsion brought about by superior oblique. Okay. So just now I told you, I'll summarize. Superior rectus elevates the eyeball to see the roof of your room or the sky. Inferior rectus will depress the eyeball so that you can see your feet or the ground. Lateral rectus especially works during examination while copying in your friend's paper. Abduction of the eyeball. Okay. On a funny note. Okay. Lateral rectus, abduction of eyeball, movement away from the midline. Medial rectus, adduction of the eyeball, movement towards the midline. Superior oblique, intorsion in an attempt to see the tip of your nose. That is intorsion. Superior oblique. Inferior oblique, extorsion in an attempt to see a corner of your room. That is extorsion. Now today's topic is oculomotor nerve, which is third cranial nerve. Oculo means eyeball. Motor means movement. So most of the muscle which are moving the eyeball are supplied by this nerve, third cranial nerve. Therefore it's called as oculomotor nerve. So it supplies all the extraocular muscle except SO4 LR6. I told you this multiple times. I am repeating for revision purpose. Superior oblique, fourth cranial nerve, lateral rectus, sixth cranial nerve. In addition to this, the oculomotor nerve also supplies sphincter pupillae of the iris, also called as constrictor pupillae. So it will narrow down the pupil, so reduces the amount of light entering your eyeball. And ciliaris muscle of the ciliary body. This will increase the curvature of the lens, thereby helping in increasing refractive index of the lens, thereby helping in accommodation, meaning getting adjusted to near vision from a distant vision. Both this happens, this constrictor pupillae or sphincter pupillae and ciliaris muscle are supplied via the one ganglia called as ciliary ganglia. But this nerve controls that ganglia, ciliary ganglia. So the functional components of the oculomotor nerve includes general, somatic, efferent. Soma means body, eyeball is body, efferent means away from the brain or the brain stem. So somatomotor fibers, they supply the extraocular muscle. Next, proprioceptive efferent fibers to the extraocular muscles are also given, and afferent are carried towards the trigeminal nerve. Okay. General visceral efferent, preganglionic parasympathetic fibers for the constriction of the pupil. Just now I told you constrictor pupillae, and ciliaris muscle that is helping in accommodation, increasing the refractive index of the lens. That you can see one more video on the parts of the eyeball, then you will understand what is that. Coming to the nuclear location. What is nucleus? Collection of neuronal cell bodies deep within the CNS is nucleus. Oculomotor nucleus is situated in the midbrain. This is the midbrain outline. It appears like a elephant's face, okay, except there is no trunk here. Okay, this is the elephant's forehead. We can think like that. You can write one outline. This is the aqueduct. This is the periaqueductal gray matter. You can see the nucleus here. That is oculomotor nucleus. At the upper midbrain, why I am telling upper midbrain? See, the red nucleus is there. So third cranial nerve, upper midbrain. Fourth cranial nerve, lower midbrain. Very simple. So oculomotor nerve present in the upper midbrain at the level of red nucleus area, at the level of superior colliculus area. It emerges forward, passing through the red nucleus and the substantia nigra, and passes medial to the crus cerebri. So it is situated in the upper midbrain. The other component of this oculomotor nucleus, other than supplying this extraocular muscle, I told you it controls ciliary ganglia. The parent nucleus of the ciliary ganglion is called like this, Edinger-Westphal nucleus. It is also situated in the midbrain. Oculomotor nerve helps this nucleus. It will drop these fibers from this nucleus onto the ciliary ganglia. Okay. So the oculomotor nerve nucleus, it's a complicated manner. They are connected to different muscles, extraocular muscles, so that the conjugate eyeball movement is possible. So if you want to know everything in detail, you can just see the simpler line diagram. Okay. So in this, all that you have to remember come from the midline. We always better to start from midline in any diagram or any notes. Anyway, you have to start from midline. It's easier for you to remember. Okay. In the midline, raphe nucleus supplies superior rectus. Raphe nucleus supplies superior rectus. Caudal central nucleus supplies levator palpebrae superioris, that which elevates the eyelid. See, both the nucleus present in midline are supplying muscles which are above the eyeball. Simplest. Raphe nucleus supplies superior rectus above the eyeball. Caudal central nucleus supplies levator palpebrae superioris above the eyeball. Next, this one. Ventromedial, dorsolateral. This is front and medial. Ventromedial supplies medial rectus. M for M. Dorsolateral supplies, don't the lateral rectus, it supplies inferior rectus. Okay, this you have to remember, because lateral rectus is never supplied by oculomotor nerve. Okay, so ventromedial nucleus supplies medial rectus, dorsolateral supplies inferior rectus, intermediate nucleus supplies inferior oblique. Intermediate nucleus, this I means intermediate, this I means inferior oblique. Next, this umbrella shape or a comma shape nucleus is there. It's called Edinger-Westphal nucleus. This controls the ciliary ganglia, which you can see here. Ciliary ganglia. Why are the ciliary ganglia? The short ciliary fibers passes through the sclera of the eyeball to reach the ciliaris muscle of the ciliary body and the constrictor pupillae of the iris. What does the ciliaris muscle do? Ciliaris muscle will increase the curvature of the lens, thereby helping in accommodation. Constrictor pupillae narrows down the pupillary size so that the amount of light entering the eyeball will be reduced. Okay. The intracranial course of the oculomotor nerve, it arises from the medial side of the crus cerebri. After emerging from the medial side of the crus cerebri, it passes forwards and slightly laterally towards the superior orbital fissure, but before that it has to reach the cavernous sinus. When it is passing forwards and laterally, it is related to posterior cerebral artery and superior cerebellar artery. Posterior cerebral supplying the brain, okay, near the occipital lobe. Superior cerebellar, that is supplying the upper portion of cerebellum. So any aneurysm of these arteries will result in the condition as I showed you in the beginning, the squint, the lateral squint or the divergent squint. So posterior cerebral and superior cerebellar arteries, it is sandwiched between the two. Then it is entering one triangular area. It's called oculomotor trigone. I will show you that in this picture. This is after removal of the brain. We'll see the interior of the skull like this. Here you can see one tent-like structure. It's called tentorium cerebelli, a fold of dura mater which separates the cerebellum from the rest of the brain. Tentorium cerebelli. You can see the cerebellum here. Here the midbrain is exactly cut. Therefore the oculomotor nerve is cut. The remaining portion pons is visible. Don't worry about that. You remember this area. So this is the free margin of tentorium cerebelli. It's also called tentorial notch. This is the attached margin of tentorium cerebelli, which is attached to the petrous part of temporal bone. Here the attached margin and the free margin are crossing one another. Attached margin is going to the posterior clinoid process. The free margin is going towards the anterior clinoid process. When they are crossing one another, it forms a triangular area. It's called as oculomotor triangle or oculomotor trigone. Trigone and triangle means the same. It's Latin, that's all. Okay. So it pierces the oculomotor trigone. The dura mater it pierces and comes to lie in the lateral wall of the cavernous sinus, which you can see in this diagram. See here. It is related to the lateral wall of lateral wall of cavernous sinus, and it is related to other nerves below, trochlear nerve, ophthalmic and maxillary division of trigeminal nerve. So it's very simple to remember. Third, fourth, and these two are branches of fifth. Third cranial nerve, oculomotor. Okay, three numbers can't you remember? 3, 4, 5. Very simple. 3 is oculomotor nerve, 4 is trochlear nerve, and 5 is trigeminal nerve. Not all the divisions. Ophthalmic and maxillary only. Why mandibular division doesn't come? Because foramen ovale, egg-shaped foramen will be very far away from here in the greater wing of sphenoid bone. So mandibular division doesn't come here. It's not bothered about this. So it will remain in different area. So this passes further, oculomotor nerve passes further through a fissure called a superior orbital fissure. Ultimately, it is reaching the orbit. Okay, it's reaching the orbit. Here it divides into two divisions, upper and lower division of the oculomotor nerve. The upper and lower division of the oculomotor nerve. Upper division supplies the muscles above the eyeball, that is superior rectus and levator palpebrae superioris. The lower division further divides into three branches supplying the medial rectus, inferior rectus and the inferior oblique. The branch going to the inferior oblique will give a tweak to the ciliary ganglion. That is important. It is a MCQ question. Which branch of oculomotor nerve supplies ciliary ganglion? A branch to inferior oblique. Okay. The course in the orbit just now I told upper division, lower division. Upper division gives only one branch to the superior rectus. Through the superior rectus goes to supply the levator palpebrae superioris, which elevates the upper eyelid. Okay. Lower division gives three branches, one for the medial rectus, one for the inferior rectus, the other one for the inferior oblique. This one. You can see that the branch to the inferior oblique goes towards the ciliary ganglion. Fibers beginning from ciliary ganglion goes and pierces sclera as a short ciliary nerves and ends by supplying the constrictor pupillae of the iris and the ciliaris muscle of the eyeball. So that is about the summary of this. Upper division one more time, superior rectus, levator palpebrae superioris. Lower division gives three branches, one for the medial rectus, one for the inferior rectus, and the longest branch will be the for the inferior oblique. That will give a communicating branch from the Edinger-Westphal nucleus. The fibers which are hitchhiking the oculomotor nerve will now reach the ciliary ganglion. Postganglionic fibers goes to supply the constrictor pupillae and the ciliaris muscle of the eyeball. Coming to the communication, in the cavernous sinus it communicates with sympathetic nerve plexus around the internal carotid artery. In the orbit it communicates with the ciliary ganglia, that's a parasympathetic ganglia. Central connection includes corticonuclear fibers arising from the motor cortex of the brain, both the cerebral hemisphere. That is because of conjugate eye movement. When you move your right eye, left eye also should move right. Therefore, both cerebral hemisphere. Medial longitudinal fasciculus, which begins from vestibular pathway, connects to the all the three extraocular muscles nucleus, third, fourth, and sixth cranial nerve nucleus. It begins from vestibulocochlear. Just now I told you. It helps in coordination of eye movement with respect to sound. If someone makes sound, you have to turn reflexly your head and neck and the eye. That's why. Okay, medial longitudinal fasciculus. Next, tectobulbar tract. It's for visuoprotective reflex. Like I just now told you, any sound comes, you should reflexly move your eye and neck towards that area. That's why it's called tectobulbar tract, visuoprotective reflexes. Pretectal nucleus of the both side, it controls for the light reflex. You can see one more video of mine on the light reflex and accommodation reflex. You will understand this. Pretectal nucleus of both sides, it's connected. Come to the last aspect, applied anatomy. In applied anatomy, you can see there is ptosis, there is a drooping of the upper eyelid. Why? Paralysis of which muscle? Levator palpebrae superioris. Then there is diplopia. Why? When there is paralysis of all the extraocular muscle, but the lateral rectus is still intact because it is supplied by abducent nerve. Then one eye will be moved towards outer aspect, lateral squint. The other eye is still looking straight. So there obviously there will be diplopia. See like this, one eye has got a lateral squint because the abducent nerve and the lateral rectus is intact. Oculomotor nerve is paralyzed. One eye is still straight, therefore the person will have diplopia. This is called external strabismus or the lateral squint. Pupil is dilated. Why? I told you just now, ciliary ganglion, through that it supplies constrictor pupillae. Okay, when there is constrictor pupillae, there will also be dilator pupillae. So pupil will be in neutral position normally. But when there is a paralysis of constrictor pupillae, the unopposed action of the dilator pupillae will result in permanent dilated and fixed pupil. That is due to oculomotor nerve damage. Next, there is a downward and outward gaze and dilated pupil, and you have to manually elevate the eyelid. Why? Levator palpebrae superioris is paralyzed. Why it's going downward and outward? Because oculomotor nerve is damaged, all the extraocular muscles are paralyzed. This lateral rectus and superior oblique is still working, therefore it goes like this. Why dilated pupil? Just now I told you, paralysis of constrictor pupillae, but the dilator pupillae is still working. This side is normal. Okay. Same thing in this patient, there is a complete ptosis, fully durable ptosis. Manually we have to elevate the eyelid, and that time you can note there is a extropia or movement, external strabismus on the outer aspect, and pupil also you can note carefully. Pupil here is normal. Here you can see dilated and fixed pupil. It's not responding to any light reflex and all. So in summary, Ptosis due to paralysis of levator palparis superioris, deviation or the external strabismus because of the unopposed action of the lateral rectus and superior oblique. These are the ocular movements which are lost actually. Abduction, elevation, depression, extorsion are lost due to paralysis of all the muscles. Pupil becomes fixed and dilated due to paralysis of constrictor pupillae or sphincter pupillae, and the unopposed action of dilator pupillae makes the pupil dilate. Accommodation reflex is completely lost due to paralysis of ciliaris muscle of the ciliary body. So the lens won't change its dimension. Then there is a cross diplopia. That is, one eye is seeing straight, the other eye is seeing outward. Divergent squint. Head posture is tilted towards one direction because what happens, to compensate for the diplopia, the person will move the head to the opposite side and tilt towards the same side so that the chin is raised. When they do like that, both the eyes look in the same direction. There are various other fancy syndromes with respect to this. Benedict syndrome, which involves the fasciculae of the red nucleus and is characterized by ipsilateral third cranial palsy and contralateral extrapyramidal syndrome. Because it's called Benedict's, red nucleus will also be involved. Okay, just remember, Benedict's means red. Weber syndrome involves fasciculae of the oculomotor nerve and the cerebral peduncle also. Therefore, when it involves cerebral peduncle, the person will have contralateral hemiparesis or hemiplegia with ipsilateral third cranial palsy. Ipsilateral means same side, contralateral means opposite side. Nothangel syndrome involves fasciculae of oculomotor nerve and superior cerebellar peduncle. Since it involves cerebellar peduncle, the person will have ataxia. That is like a drunken gait, cerebellar ataxia. If the third cranial nerve is involved on one side and the person has ataxia on the other side, the person is called as Nothangel syndrome. Claude syndrome is a combination of Weber syndrome and Nothangel syndrome. In this syndrome, there will be paralysis on one side with cerebellum ataxia on the other side and cranial nerve palsy on the same side. It's a combination of Benedict syndrome and Nothangel syndrome. Benedict syndrome and Nothangel syndrome combination. Okay. Like and share this video with your family and friends. Don't forget to press the thumbs up button. Subscribe to my channel and press the bell button to get the latest notification of the video. Thank you for watching this video. Kindly press the thumbs up button and share this video with your other friends so that they can also learn like you did just now.